Hi, I'm Dr. Alison Kole, sleep medicine specialist and bona fide chronic insomniac. Welcome to the Sleep is My Waking Passion podcast. Remember, knowledge is empowerment, and if applied correctly, it can help you biohack your way to a better night of sleep, just like I did. If this resonates with you, please follow me on Apple, Spotify, or your favorite podcast app. Welcome, everyone, to the Sleep is My Waking Passion podcast. Very new to this, and I have been fortunate to have such wonderful mentors in my life who encourage me to be the independent person that I am. And the person that we're going to be speaking with today is Dr. Jennifer Martin. She is a PhD. She is trained at some really big deal places. She was at Brown. She's currently at UCLA. She's actually a professor of medicine at UCLA. And she did some of her fellowship training there. And she also trained at UCSD. Dr. Martin, welcome.
Thank you.
Am I allowed to call you Jen?
Please do.
I feel weird because you are my mentor.
I know. We've known each other for a long time. Please, first names.
I'm going to brag a little bit and say that Dr. Martin actually remembers who the heck I am from fellowship. So that's a win score. My personality actually shined upon her to a certain extent.
And your skills and your smarts.
Jen, you are currently president of the board of directors of the American Academy of Sleep Medicine, correct?
That's correct.
Tell me how that came about, because if I am understanding this correctly, you were the first non-MD, you're the first PhD to be in charge?
I'm the first psychologist. So years ago, there were two neuroscientists, Tom Roth and Jim Walsh. I'm the first non-physician in a very long time and the first clinical psychologist, and only the sixth woman, actually.
All right. So this is groundbreaking on multiple levels. What have you been up to in terms of the research world? You're still at UCLA, correct, from when I was in training?
Correct. I split my time at UCLA and the VA. My research has been focusing on two things: insomnia, and I've also started doing research on sleep apnea in women. What I really like to focus on in my research is groups of patients who struggle with standard recommendations for things. So in the insomnia space, I'm now working with veterans who have post-traumatic stress disorder. As I mentioned, I've been getting more interested in women who have sleep apnea because it so often is overlooked and undiagnosed compared to men who have the same symptoms. Really where I think my heart and the bread and butter of what I do is in trying to find ways to help people who are struggling with insomnia to get a good night's sleep.
So if we were to say, just in terms of defining quote unquote insomnia, right? We're not talking about that patient or that person who's like, listen, I've been through a stressor. I've had a few nights of crappy sleep. Now I'm kind of getting back into my natural rhythm, right? So let's define chronic insomnia.
Let me start by just reiterating a really important point that you made, which is a bad night of sleep now and then is normal. It's actually a really adaptive response to stress. I mean, if you think about before we had houses to live in and we had to live outdoors or in caves, if there was something dangerous, if there was a threat, it would be really unfortunate if we just fell asleep anyway. So we're wired to be awake in the face of danger. Of course, we don't have the same dangers anymore. It's like paying tuition for my kid's school, or my mom fell down, or my husband lost his job, or whatever it might be that people worry about. But our brain still reacts the same. And for most people, when the stressor resolves or they sort of adapt, as you said, they get back on track. But for a subset of people, that doesn't happen. And we definitely saw this happen during the COVID pandemic, where because of financial stress, illness, just general stress, there was a lot of political unrest during the pandemic years. A lot of people started to develop sleep problems. And when insomnia kind of takes on a life of its own and it persists for a long period of time, that's what we are talking about. So to be really concrete, if a person has trouble falling or staying asleep, or they wake up really early in the morning, that happens at least 3 times a week and goes on for 3 months or longer, that's where we start thinking about a chronic insomnia disorder. And then we do want to think through, can we identify a root cause? So maybe the person started on a medication at that time and we say, aha, that's the problem. Or a person developed a new medical condition and we might think that's the problem. But what normally happens is, even in the context of other conditions, chronic insomnia becomes its own clinical entity that we have to address directly.
So if we're looking at trying to figure out what are realistic goals for a patient to have, I think that's a really important question because I've seen that where folks are coming to me and they'll be quoting a little blip from the internet that they read and perceiving that somehow they may potentially have an issue.
Yeah.
So, when we're looking at the way we sort of define a success in being able to manage insomnia, what can patients or what should they sort of expect as being a realistic goal?
Well, I forgot to mention one of the really important criteria, and that is that the person's sleep problem has to affect how they feel or function during the daytime. So it's a little different than people who, for example, just feel fine after 6.5 hours of sleep. Someone with insomnia sleeping 6.5 hours doesn't feel well. So when we think about benchmarks for success, I really focus on the daytime as much as the nighttime. So I think a lot of people get really hung up on how many hours they're sleeping. And I actually have a patient right now that I'm working with who is getting about the same amount of sleep as he was when we started, but it's in one solid block. So he used to sleep kind of 6 hours here and there, maybe an hour during the day, few hours, and up in the middle of the night. He's still only sleeping 6 hours, but it's in one solid block and he feels like a totally different person. So I think a realistic goal is that the quality of a person's sleep improves and that they start to feel better during the day. I'll also add that this is sometimes a challenge when we look at sleeping pills, because a lot of times sleeping pills fix the nighttime problem a little bit. But when you ask the person how they feel when they get up in the morning, they say they feel terrible. So I like to think like that's not what we're aiming for. That's not always the case, and it's not true for every person or every sleeping pill. But I find that, if people are having a hard time falling asleep and they take a pill and they fall asleep faster, the assumption is, well, I should be better. But I would kind of make the argument that if you're still feeling kind of hungover and groggy in the morning, we've kind of put a Band-Aid on it, but we haven't really fixed the problem.
Right. It's funny because I remember these guidelines kind of being a little on the old side 10 years ago. There's been a recent update to the American Academy of Sleep Medicine guidelines for treatment of chronic insomnia. And again, folks, we're focusing on the adult population. We're not talking about kids here. And it's been a long time coming because I think the original guidelines were like 2006. And then in 2021, you guys were really busy in the pandemic coming together and creating these guidelines. And the number one or the best researched in terms of the strongest data or the strongest recommendation is actually not pharmacotherapy. It's not a sleeping pill. It's this umbrella term, or how I look at it, and you can correct me, but what we call cognitive behavioral therapy for insomnia. Can you tell us a little bit about what that means? Because it seems like it's a lot of multiple parts kind of strung into one.
Yeah, actually, in the guidelines, we were pretty specific. I'll just use CBTi as like kind of a shortcut. CBTi is a multi-component treatment. So it has different pieces that people have kind of figured out to put together. And the package is what seems to be most helpful. Not to say that the individual pieces don't help, but it seems to work best if you do all the pieces together. So it includes things like sleep scheduling, so that the person is in bed for the right amount of time at the right time of day or right time of night, I guess. So, I'll use myself as an example. I sleep about 7.5 hours a night, and I know I usually fall asleep around 10:30, and then I can kind of sleep through until the morning. Well, if I got into bed at 8 p.m., I would have sleep onset insomnia. I wouldn't be able to fall asleep. So it's not just how much, but it's exactly when someone should be in bed. And then we deal a lot with stress and anxiety around sleep and things that come up at night. So as a clinical psychologist, sometimes I think about this as a variant of dealing with anxiety. It's just anxiety that's specifically around sleep most of the time. And then, we do tackle a lot of those kind of basic habits like caffeine, alcohol. Is your sleep environment comfortable? Do you feel safe there? Those sorts of issues. So that package of recommendations seems to work best for most people, and it works pretty quickly. Most of the research has been done with people working one-on-one with a healthcare provider like me. But over time, there have been some interesting innovations in app-based delivery of CBTi or online programs. And we do see now in multiple studies that you can do CBTi with telehealth or in person, and it's equally effective. But for some patients, even self-directed treatments can be very effective. It's something that's worth trying. I think finding a psychologist who can do CBTi can be tricky sometimes, but the bottom line is it seems to work well for most people most of the time. And I think if you're the kind of person who struggles with insomnia and feels comfortable doing something on your own, then there's nothing that should prevent you from doing that.
In terms of duration, one of the findings that I noted was there's been an evolution since when I started and I trained with you where it was really sort of perhaps it wasn't in its infancy for you, but the way I thought of it was, all right, we have this dedicated program. It is difficult to find psychologists. And now there are even folks with social work degrees and other types of behavioral therapists who may not specifically be clinical psychologists who do this kind of work. But it was sort of centered around that one-on-one interaction or a group working, right? I remember you guys were doing a lot of work with the VA where you'd have group sessions. And nowadays we've sort of segued into the shorter behavioral health type of interventions. And as you mentioned, they can be equally efficacious. They could both really be helpful. Is there a difference between, let's say a 4 to 8 week session, the cognitive behavioral therapy versus the shorter session? And has that changed how you practice because the data seems to be equivocal?
4 to 6 sessions seems to be the sweet spot. There are brief interventions that, people refer to as brief behavioral therapies that are in that 2 to 3 session range. The evidence suggests that those approaches are a good option for some patients, whereas CBTi works for most patients, if that makes sense. So when we wrote the guidelines, there were like about 75 randomized controlled trials of CBTi in that 4 to 8 session zone, and it was very effective. In the brief behavioral therapies in that 1 to 3 session zone, I think there were about 10 or so studies, and the results were promising, but one of the things that happens is sometimes patients don't totally improve by the end of treatment. They keep getting better on their own after. And for some people, that's fine. They just sort of need a guide, and then they can go out and execute the plan on their own. What I think is going to happen going forward is that we'll get better at figuring out who needs what. I would like to see more research on treatment matching, like who's appropriate for, here, I'm going to see you one time for an hour, I'm going to give you all the instructions, and I'm going to send you out into the world. Versus, no, this is somebody who's going to need a little extra support and troubleshooting, and we're going to try something and it's not going to work, and they're going to come back and it's going to take us 4 or 5 weeks to figure it out.
Oh, that would be amazing to even understand that.
Wouldn't it?
Because I feel like on a personal level,
yeah,
when I've interacted with various patients, I can't say that I've been able to predict.
Me either, honestly.
I've had folks that literally have been like, this was an amazing session. I did everything you said. My sleep is fixed. Bye-bye. And I'm like, what just happened? And then I'll have someone else where I'm like, I really think that I resonated with them. They kind of understood what I was saying, and then it doesn't help, or it helps temporarily, and we still have to use some pharmacotherapy.
Or they come back and they say, yeah, you know what? I totally got the plan, but it's just not going to work for me because I forgot to tell you that I have to take my kids to school 4 days a week. Oh, yeah, right. So that's where I hope we're headed, is kind of a more where we get better at figuring out who needs what, and we get patients the right treatment first. I will say that I am not a fan of what people call stepped care, which is starting with like the lowest level intervention first and then going up. I think if we have a really effective treatment, everyone should get that first.
Like hit them hard.
Yeah. I always say, like, if you have cancer, they don't say, well, let's try this partially effective chemo first and see what happens, and then we'll give you real chemo later. Like, no, we work really hard to get everybody the best treatment right up front. Not to equate insomnia with cancer, but I find it kind of strange that we think, like, let's see if someone fails this before we give them something else. There are some people who are doing non-inferiority trials, looking at whether these brief interventions are similarly effective to CBTi. And I think what will come out of that research, although it's not the primary goal, is to figure out who it works for. So hopefully in the next few years, we'll have some data on this.
Are there specific patient populations? I'm going to kind of lean this toward the PTSD patients, just because given your experience working in a VA environment, I think that would be like a huge thing that I've observed during my time there, and also having had patients who may seek care in a private practice environment, even though they're veterans. Are there specific things for that population that are sort of unique, or any specific psychiatric disorders in particular that you've noticed a theme, even if it's not studied in a randomized fashion or in a large cohort setting.
Yeah. Well, it's really interesting because it's not just veterans with PTSD. I mean, there are a lot of, women who are victims of domestic violence, people who are in accidents, natural disasters, COVID, right? I think exposure to trauma can change our relationship with sleep. And sometimes, this isn't true for everyone, but for some people, a traumatic event that causes PTSD is also the thing that triggers their insomnia. And so when we think about post-traumatic stress disorder, we think about a person who's experienced a traumatic event and then continues to have symptoms associated with that event for a long period of time. So nightmares are a really common symptom. What we call hypervigilance, or like feeling constantly on guard. Those are the kinds of things that make sleep really difficult. One of the things that we do notice in people who have trauma experiences at night is it can be very difficult for them to feel safe. So we see this in women who are domestic violence victims and people who've been in wars where nighttime wasn't safe. It's like they go on guard duty at night. And so one of the things that we're actually now working on is how do we adapt CBTi so that it's most effective for people who have experienced trauma. And one of the things we're finding is that we really have to focus on safety at night and be really thoughtful about that. Because if you don't feel safe in your sleep environment, then it can be really difficult to get a good night's sleep. And some of the things people might do to try to feel safe, like when they wake up, they patrol the perimeter of their house. Well, it's really hard to fall back asleep if you just had to get up and, sometimes they take a firearm with them, and we always worry about what could happen if there was an accident when they're tired in the middle of the night. One of the things we've started working on is focusing specifically on how can we think about nighttime as a safe time, right? Not the place where you experienced your trauma, but actually a safe place. And then doing simple things like have a checklist to make sure you really did check all the windows and doors before you got into bed. Get an alarm for your door. Have a dog. I mean, there are things that people can do to help themselves feel safe so that they aren't so afraid to fall asleep at night. That's something we see a lot in post-traumatic stress disorder.
I'm going to ask a somewhat personal question. Just from my experience, I would make the argument that having gone through the ICU care of COVID patients, for me, and I could say for other colleagues too, I think is a form of like trauma there. I mean, it was very bad outcomes. On the East Coast, we were hit the hardest. And even though I would wholeheartedly tell you that I 100% believe we all tried our hardest and we were figuring stuff out when there was nothing. Just people saying, give everybody Plaquenil and azithromycin, and we're seeing QT prolongation all over the place, and we're stressing out about that. There wasn't anything at that time, no remdesivir, these other treatments. And I've always sort of struggled with sleep, which is why I think you had such a profound effect on me and why my sleep fellowship had such a profound effect on me, because I was like, oh, my solution in my 20s was just to take extra call and make some money because I couldn't sleep anyway. So what was the point? That was a maladaptive response, but they don't really tell you that.
No, they're happy to have you working the extra shifts, right?
Yeah, exactly. And I was happy to buy a car at the end of that circumstance. I felt like that was my reward, but
right.
I'm probably speaking similarly to other folks that may not have had the nocturnal trauma or the trauma associated with something specifically happening at night. But what I can tell you in my experience, and I know I'm not alone, I could function. I could go to work. I could be distracted. I could spend 12 hours seeing patients and doing all these sorts of tasks. And then it would come to go to sleep at night and I could not shut my brain off. It was and it would be, sometimes it would be about COVID or a patient case or, did I tuck everything in? Did I miss something? Could I have done a better job? That was really something that affected me. And I'm sure it affects other people in a different kind of way. What advice do you give folks like that, where it's almost like their brain just goes, I'm exhausted. I'm physically feel like I'm ready to engage with sleep. Now, all of a sudden, I'm going 1,000 miles an hour.
Yeah. I mean, this is so common. It's funny because last night I woke up in the middle of the night and started worrying about one of my friends. I don't know why. And I just thought, okay, this is really not the time for this. So I got up for a few minutes and kind of just disconnected. And then I got back in bed and fell asleep. But it happens, right? And I think one of the reasons is you use the word distraction during the day. We have things that occupy our brain. And so those, kind of underlying concerns, they just get buried. And that's fine. But then when you're in bed at night and it's dark, once you have one thought, then it leads to the next one and the next one and the next one. And we can get to some really dark places at night too in our thinking. So the advice that I actually give people is to try to get out of your head. So I'm a big fan of mindfulness and grounding exercises at that point, like focusing on physical sensations. I have like some favorite exercises. Those are the kinds of things where anybody who practices yoga or Tai Chi knows what I'm talking about. Where if you have to focus on your physical body and that allows you to clear your mind. So the old school version of this was kind of like diaphragmatic breathing or things like that. But that can be really helpful to people, is to just get out of their own way in some sense. And then the other thing is, everybody's heard the recommendation, oh, if you can't sleep, you should get out of bed. I think about it a little differently. And I think like the bed is not the place for the struggle. If you're in bed and you're awake and you don't care, like just stay there. It's not that big of a deal. But when you start to really struggle and start thinking like, oh man, what time is it? How long have I been awake? I often joke you can't sleep and do math at the same time. If you're adding and subtracting minutes or hours, get up and do something else, take your mind off it and get back into bed when you're sleepy. That's almost like just a good sleep habit for everyone in general, not to have a tug of war with a monster in your bedroom. Just take it outside.
I've had some folks who have mentioned to me that if they distract themselves, like listening to an audiobook
Yeah.
or listening to some music, or even they have a lot of things. For me, I found that along the lines of mindfulness, they do have these ones to like yoga for sleep or like a meditation for sleep, self hypnosis, which I kind of think in my mind, I look at it as sort of a form of meditation. I found that sometimes if I'm really desperate, that has been very helpful. Has that been your experience?
This is an alternative to what I was mentioning. Rule number one, don't struggle with sleep in bed. It's easiest if you get out of the bed, but if you can get rid of the struggle by doing something else, that's perfectly okay too. There's a channel that's the British Shipping Report. Have you ever heard this? It's hysterical. They like give like waves and wind, and it's like this monotonous male voice just like droning on and on. And it's really boring, but it's also kind of interesting. Again, it kind of has to get you out of your mind. The caveat to that is, I've had people say like, okay, when I can't sleep, if it's been 15 minutes, I'm going to listen to a podcast and I know it's half an hour. And if I'm not asleep by the end of that podcast, I'm going to try even hard. It's like, no, the idea is not to use the podcast as a timer to see how long you've been awake or white noise or something like that. It's a very individualized thing. And so what one person might find relaxing, another person might find activating. But you're really heading in the right direction with that. The point is, don't fight with sleep in bed. You can't win because the harder you try, the faster it runs away.
You get into this vortex of like a negative kind of cycle.
Yeah.
Are there any sleep trackers online or otherwise? I know the VA had designed the CBTi coach tracker, which is nice because it's free, so it doesn't cost anybody any money. Are there any tools that people who are interested in learning how to improve their sleep could use that you would recommend or have had personal experience with?
It's tricky because one of the problems that a lot of people with insomnia have is that they focus too much on their sleep. So if people are struggling with insomnia, I usually don't recommend that they do a lot of tracking. The other thing is that the tracking it can kind of be upsetting because it'll tell you things like you don't get any REM sleep. And the truth is they're not that precise at that level. On the other hand, when people are kind of feeling tired during the day and they're not sure what to do differently, or they're trying to implement a more consistent schedule, that's where the tracking can be super helpful. For example, if I have a college student, let's say, who is tired and has class early on some days and we're trying to kind of even things out, having a tracker can be a good way to just look at where your sleep window falls in 24 hours. And I don't necessarily have a favorite. I think the ones that use movement and heart rate seem to be more accurate these days. So like the Aura Ring, Whoop Strap, Fitbit, like there's a laundry list of them.
So they don't even have to input data really. They could just use one of these things as long as it's not interfering with their sleep.
Yeah, I mean, again, kind of accepting the caveat that when it tells you you're in light sleep or deep sleep or REM sleep, it's really not much more accurate than flipping a coin. However, they're reasonably accurate at just knowing whether you're asleep or awake. That's where I think they can be helpful. Again, is like, where are you putting that window, that opportunity for sleep? And is it consistent night over night?
I'm laughing a little bit because I believe when you review some of these trackers, the stuff they claim, like if you don't have an actual indication from the FDA
Oh,
and you're
yeah.
a commercial product,
Yeah.
the world is your oyster as far as whatever claims you can. And then they'll say, well, we have data, but it's proprietary, so we can't share it with you.
Yeah.
At least that's
Yeah, they don't share their algorithms. And their so-called data sometimes is like 5 healthy young men who wore it for a month and then they optimize their algorithm. When you have a 72-year-old woman with heart disease and who's taking medication, who knows how accurate the algorithms are for that. There is another advantage, though, to trackers that I feel like we never talk about, and that is, being active during the day helps you sleep better. As long as you don't like overdo it. I think the motivation to be active consistently, while it's not like an insomnia treatment, it really does kind of put scaffolding around good sleep.
Oh, 100%. I think that's if I have to think a contributing factor to my difficulty, it was that I left feeling so sort of emotionally depleted that my behaviors where I was exercising regularly, for me, lifting really helps. Is if I lift the weights, for some reason that triggers a different part of my brain and I'm like, I'm getting strong. This is awesome.
Right.
And that sort of fell to the wayside because I was just like, okay, great. Now I'm like 12-hour shifts. I'm up overnight and I'm not used to doing this because I'm not 25 anymore. And that really kind of mucked around. It took me a while to get back to a place. And I would say I'm 80 to 90% back there. But even with a transition out of what I was doing, you have to be patient with yourself, I think, is one of the things too with insomnia in general, that it's about kind of not trying to have that like quick fix, which is, I think, what a lot of people want.
Yeah.
And the sleeping pills certainly may offer that, though it's interesting because even some of the data for the sleeping pills is like the reduction in sleep onset latency or the reduction in your wake after you fall asleep may really be 15 minutes or even less in some cases.
What's really interesting to me about sleeping pills is that placebos work really well. So, I sometimes joke if I ever have insomnia, like I want somebody to just like slip me some Skittles or a Tic Tac or something because
Tell you they're magical. You'll have dreams.
yeah,
What's at the end of the rainbow?
I think what it is, once you feel like you've done something, you stop trying. So if you think like this pill is going to put me to sleep and so I don't have to work at it anymore, that's really powerful because sleep only happens when you don't try. Or I'll have people who say, I struggle for like 3 hours and then I give up and take a pill. And I have to say, well, it's the giving up that helped you fall asleep, not the taking the pill. Because to your point, the difference between placebo and active medication in a lot of the trials is not something that most of us would be satisfied with. But when you go to your doctor and you get a prescription, you get all the benefits of the placebo and all the benefits of the drug, except that the placebo effects don't stay.
That's true.
That's the thing.
Yeah. As we come to the end of your time, I want to be respectful of the fact that you are a busy woman. I wanted to ask you if you knew about the data that, so the guidelines really focus on cognitive behavioral therapy sort of versus placebo. At least my review of it seemed to be that way.
Yeah.
What about cognitive behavioral therapy compared to pharmacotherapy? Because there is some data on that.
Yeah, we're actually working on that right now. At the AASM, we have guidelines on medications and we have guidelines on behavioral treatments. They're separate. And part of that is our target audience is clinicians who've sort of picked a path and then helping them down that path. But there are a handful of head-to-head studies or treatment sequencing studies where you try one and then the other. And other organizations, including the American College of Physicians, have made more head-to-head recommendations. So usually what's recommended is that you try not using medications. You try CBTi first and add medications if needed. I think what happens for a lot of patients, though, is that they don't talk to their doctor about their sleep problem until they basically would do anything to make it go away. They walk in and they're like, I haven't slept in a week. That's the time that they finally pick up the phone and make an appointment to see a healthcare provider. And at that point, I think whatever the doctor has to give them is good enough. And it's very hard for the doctor to say, look, I totally hear you. Here's a number for you to call this psychologist, and then they're going to call your insurance company and see if they'll approve 8 sessions for you, and then maybe you'll see them in 3 months. That's not the space where people are when they go to their doctor and say, I need help. That's a problem not for patients. That's a problem for the healthcare system. I mean, we got to own that, right? That's our fault. Like, our system is broken. But I do try to encourage people, like, to actually start a conversation with their doctor, not when their insomnia is at its worst. Maybe download CBTi Coach, or there's another free app called Insomnia Coach, and keep a diary for a couple weeks. That in and of itself can be very eye-opening. And sometimes people can recognize things like, gee, I'm getting in bed and I'm not falling asleep for 2 hours. Why don't I just go to bed when the time that I'm naturally falling asleep? Like, sometimes just the tracking helps people. I mean, you tracking, not using a tracker. And that can be a good starting point for a conversation with your physician.
I think that's a wonderful point, because what you're emphasizing is, listen, you and I both know the healthcare system is broken.
It is.
There's a lot of room for improvement. And one of the workarounds is, how do we be creative as clinicians in doing so?
Right.
And I love that idea of saying, listen, there are these things that cost you $0, and it may take you 3 months, maybe even longer, depending on what area you live
Right.
in order to be able to see someone. But these are the steps that you can take to fix your sleep. And one of the themes of this podcast is to try and reach folks and really create empowerment through knowledge. That's why I'm having these discussions with folks like you, to try to share some of the insights and to, like, pull back the curtain a little bit into, like, what us nerds like to talk about in sleep, which is perfectly okay. And for people to understand that we too will struggle from time to time, and some of us more than others. And hopefully you guys will understand that you can do a lot about your sleep, and you don't necessarily need to take a pill. We didn't get into the potential for there to be side effects associated with sleeping pills, but there are some serious concerns that we have. And if we can find ways to manage you, just know that you're not alone. And there's data that actually supports this. These are people that dedicate their lives to doing research, like Dr. Martin. Dr. Martin, I just want to end, Jennifer, I just want to end by saying thank you so, so much for taking the time to chat with me.
My pleasure.
I may want to pick your brain in the future.
Anytime, you have my number.
I'm just excited to have folks in my life that have inspired me, you being amongst them.
Thank you.
And you're doing good work. So stay in the fight, because it's awesome.
Thanks. It's good stuff.
Take care, okay?
Thanks, Alison.
I really appreciate you tuning in. If you think this podcast would help others, please take the time to rate us. It's the only way that our message can get out there. If you're interested in a sleep medicine consultation with me, I am currently seeing patients in the New Jersey and California area and coordinating care with Oak Health Center. You can find out more information by going to www.oak.care. I really hate to have to do this, but these are my terms and disclaimer. This podcast is intended for persons 18 years or older. This podcast provides general information and discussion about medicine, health, and related subjects. The words and other content provided in this podcast and in any linked videos and materials are not intended and should not be construed as medical advice. If the listener or any other person has a medical concern, he or she should consult with an appropriately licensed physician or other healthcare worker. The views expressed on this podcast and YouTube channel have no relation to those of any academic, hospital practice, or other institution with which the authors are affiliated. There is a detailed terms of use agreement. You can see it all on the YouTube channel. In the interest of brevity and the fact that it's legalese and really hard to read, I am not going to read it. But accessing, reading, or otherwise using the podcast or YouTube channel does not create a physician-patient relationship between you and me. Providing personal or medical information to me does not create a physician-patient relationship between you or me or any other contributors to this podcast. Nothing contained in the site is intended to establish a physician-patient relationship, to replace the services of a trained physician or healthcare professional, or otherwise to be a substitute for professional medical advice, diagnosis, or treatment. You hereby agree that you shall not make any medical or health-related decision based in whole or in part on anything contained in the site. You should not rely on any of the information contained in the site and related materials in making medical, health-related, or other decisions. You should consult a licensed physician or appropriately credentialed healthcare worker member in your community in all matters relating to your health. You agree to indemnify and hold the author harmless from any claim or demand, including attorney's fees, made by any third party as a result of any content posted or made available to you by the site, any violation of law that occurs by you through the site, or anything you do using the site or the content contained therein. This entire disclaimer also applies to any guests or contributors to the podcast.